All right, engineers, in this video, we're going to talk about what happens whenever your blood pressure is too high. If you guys haven't already, please go and watch the video on what happens whenever your blood pressure is too low. The reason why is that this video is just going to build on top of that. So watching that video before is going to give you a very firm foundation before you guys come and watch this video. Okay, so again, what we're going to talk about in this video is how the body is going to develop these compensation mechanisms whenever our blood pressure is going to be too high. So let's go ahead and get started on that. First off, what do we call high blood pressure? We call it hypertension. Okay, so we call high blood pressure, we refer to as hypertension. Now, hypertension, we can really say, is whenever the actual systolic blood pressure is greater than 140 millimeters of mercury. And we can also consider it to be hypertension whenever the diastolic blood pressure is greater than 90 millimeters of mercury. Okay? Normally we like it to be 120 over 80. But whenever the systolic blood pressure is greater than 140 or greater than 90, we consider it to be hypertension. So for example, greater than 140, you have what's called systolic hypertension. If the diastolic blood pressure is greater than 90 millimeters of mercury, you have what's called diastolic hypertension. Okay? Now, let's go ahead and mainly focus here on just what happens. We're not even going to get into all the depths of that because it can start getting really confusing. Let's just say, again, the blood pressure in general is too high. Okay? That's it. We're just going to say that the blood pressure is too high. Again, what are the structures in our body that are responding to these changes in the pressure, the blood pressure? If you guys remember, they were called the baroreceptors, and we had two types. We had the baroreceptors, which are located right at this bifurcation point. Remember, I'm going to kind of denote it here, common carotid artery, and then it splits into an external carotid artery and an internal carotid artery, right? So we have two parts here. We're going to have an internal carotid artery, which is going to be a branch, and then we'll have what's called an external carotid artery, which is another branch. Right at this bifurcation point, you have a bunch of these baroreceptors, which are located within the carotid sinus. Also, here's your aortic arch. On the aortic arch, you're also going to have a bunch of baroreceptors that are located within this sinus, which is called the aortic sinus. So again, what are these guys here called? They're called your baroreceptors. These are the baroreceptors located in the aortic sinus. These are the baroreceptors that are located within the carotid sinus. Now, just because we've already talked about it in the other video on low blood pressure, what is these cranial nerves here? The cranial nerve that's located within the aortic sinus, the sensory nerve endings, is going to be for cranial nerve 10. And then the sensory nerve endings that are going to be here within the carotid sinus is going to be for that of cranial nerve 9. We also call cranial nerve 9 the glossopharyngeal nerve, cranial nerve 10 the vagus nerve. Now, these guys are going to respond to changes in the blood pressure. And I'm going to show you the exact mechanism like we saw in the other video on low blood pressure. But what happens is these guys feed information to a special nucleus located within the medulla. This nucleus is called the nucleus of tractus solitarius. Okay, I'm going to denote it NTS. Now, first off, we're going to try to stimulate these bad boys. We're going to try to stimulate the baroreceptors that are located within the aortic sinus, and we're going to try to stimulate the baroreceptors located within the carotid sinus. But how do we do that? Let me zoom in on one of the actual sensory afferent nerve endings here. Okay? Remember I told you that whenever the blood pressure is too high, what's it going to do to the actual blood vessel walls? It's going to exert a force on the blood vessel walls and stretch the blood vessel walls. When it stretches the blood vessel walls, it activates these special channels. These special channels on the actual sensory nerve endings membrane. When these channels are activated due to stretch, it's going to bring sodium ions into the sensory afferent nerve endings. As the sodium starts flowing into the sensory afferent nerve endings, what starts happening to the inside of the sensory afferent nerve ending? It starts becoming very positively charged. As it starts becoming positively charged, it develops depolarization. And then the depolarization is going to lead to action potentials. Okay? So what's going to happen here? Increased stretch due to increased blood pressure activates the sodium channels on the sensory afferent nerve endings, allows for sodium to flow in, depolarizes the actual afferent fibers, and then sends action potentials down cranial nerve 10 and cranial nerve 9 into the central nervous system, specifically to the medulla where the nucleus of tractus solitarius is. Okay? Now, at this point, it's going to send signals to 3 different centers within the medulla. Okay? If you guys remember, we said that this red center here is going to be the cardiac excitatory center. Okay? Then we said that this brown center is going to be the vasomotor center. Okay? We denoted it VM, right? So vasomotor center. But I want to say something else about the vasomotor center. There's actually, in the vasomotor center, let's say here we have the actual whole nucleus. In the vasomotor center, there's actually 2 nuclei that are 2 areas that are really important. One is called the C1 area, and the other one is called the A1 area. Now, C1 is specifically for constriction of the vessels. So this one is mainly for the constriction, okay? You can kind of remember that by C. There's a C in the C1 and C in constriction. So constriction. The A1 is for vasodilation. And I like to remember that there's an A in vasodilation, A in the A1 area. Okay? So really, if you guys watched the video on what happens when there was low blood pressure, well, low blood pressure stimulated the C1 area of the vasomotor center. In this situation, it's going to inhibit it. It's going to inhibit the C1 area and stimulate the A1 area. Okay? So that's kind of what happens here. So really, we say before the vasomotor center was being stimulated in low blood pressure, in high blood pressure, it's going to be inhibited. But really, if we want to be super particular, it's inhibiting the C1 area and stimulating the A1 area. Whereas in low blood pressure, it was stimulating the C1 area and inhibiting the A1 area. Okay? All right, enough of that. Now, if the blood pressure is high, would we want to stimulate the cardiac excitatory center? No, because it's going to increase the heart rate, increase the cardiac output, which is going to increase the blood pressure even more. No frickin' way. We don't want to do that. So we're going to want to inhibit this guy. Okay? So let's inhibit the cardiac excitatory center. Next thing, what's this green center called? This green center is called the cardiac inhibitory center. But remember we said that this cardiac inhibitory center is connected with the parasympathetic nervous system. If you remember, I said the cardiac inhibitory center is pretty much a part of what's called the dorsal nucleus of vagus, the parasympathetic fibers of the vagus nerve. This guy is a part of the parasympathetic nervous system. Cardiac excitatory is a part of the sympathetic nervous system. You would want to activate the parasympathetic. Why? Because the parasympathetic is going to slow down the heart rate. Okay, so what am I going to want to do to this center? I am going to want to stimulate the actual cardiac inhibitory center. Okay, let's see how all of this is going to be affected then. So first off, if I inhibit, let's say here was my cardiac right here, this one right here, I'm coming down here. Remember it went down to about the T1 to L2 region, activated these preganglionic fibers that went out to a chain ganglia, and then from the chain ganglia, you gave off the postganglionic motor neurons. And then what happened? These guys we said came as a part of the cardiac plexus, went to the heart to where the SA node is. And it also gave fibers to the ventricular myocardium, and it also gave fibers to the AV node. Well, if we inhibit these fibers, so if you've inhibited the cardiac excitatory center, the action potentials that are moving down these fibers are going to pretty much decrease or be completely absent. If these decrease or become completely absent, are you going to be stimulating the SA node anymore with adrenergic drive, releasing norepinephrine? No. So that's not going to be having any stimulation. AV node won't be getting any stimulation from the sympathetic nervous system, and the myocardium won't be getting any innervation from the sympathetic nervous system, right? Same thing with the vasomotor center. Remember, the vasomotor center brings down fibers that also is becoming a part of the T1, L2 region, and this gives off fibers that does what? These fibers come out to a chain ganglia, and they go to a specific area. What is that area? Remember, they go to an actual arterial where the smooth muscle is. What was that muscle here in that area called? It was called the Tunica Media, if you guys remember. Remember how it's called the Tunica Media? It's the smooth muscle layer in the blood vessel. Well, here in the arterioles, we're going to have Tunica Media with sympathetic receptors, which is, remember, releasing norepinephrine. But in this situation, what's the problem? We inhibited this system. So if this system has been inhibited, here's the vasomotor center. If this is inhibited, it's going to inhibit the action potentials. And so there's going to be pretty much no action potentials or very little action potentials that are being moved down these sympathetic nerves. If you're releasing very little action potentials, then you're going to release pretty much no norepinephrine. If norepinephrine is not acting on these alpha-1 adrenergic receptors, it's not going to be constricting the vessel. If it doesn't constrict the vessel, what happens? So if there's very little, so let's actually not get rid of it. Let's say that pretty much norepinephrine release significantly decreases or just completely becomes null in this point. Then whenever it acts on this area, this receptor is going to be inhibited in this case because it's not going to have any type of stimulation by the norepinephrine. What type of receptor was this again? Alpha-1 adrenergic receptor. If this is the case then, if this smooth muscle is not receiving norepinephrine, then the muscle, the actual smooth muscle, is going to relax. So there's going to be relaxation of smooth muscle, or the tunica media in this case, right? If the smooth muscle relaxes, what starts happening to the actual diameter of the blood vessel? It starts getting bigger. What is that called? When the blood vessel starts increasing in size, the lumen gets bigger. It's called vasodilation. And what does vasodilation do? It increases the diameter. Well, what's half of the diameter called? Radius. If you increase radius, what's that formula called? Poiseuille's equation, which says that radius is equal to 8 times the viscosity times the length over pi r4. If I increase the radius, it's going to do what to the actual resistance? It's going to decrease the resistance significantly because these are inversely proportional. So the resistance, the total peripheral resistance, is going to significantly decrease. So now if I decrease the total peripheral resistance, what does that have anything to do with this? Well, if you guys remember, we said that blood pressure is equal to cardiac output times total peripheral resistance. Well, I significantly decrease my total peripheral resistance. What is that going to do to the blood pressure? It's going to decrease the blood pressure. So as a result, what's going to happen? I'm going to decrease my BP. And that was one of the problems, was where I had too high of a BP. I just kind of addressed it right there by doing what to the blood vessels? Dilating them, decreasing the actual resistance. So that's one way that we can fix it. So again, one way that we're going to fix this is we're going to inhibit the vasomotor nerve center, which is going to basically decrease the sympathetic impulses that are going to the tunica media. If you decrease the sympathetic impulses that are going to the tunica media, then what's going to happen? You're going to release less or pretty much no norepinephrine. If less norepinephrine or pretty much no norepinephrine is being released, you're not going to be causing the smooth muscle to contract anymore. So now the smooth muscle will start relaxing. As the smooth muscle starts relaxing, it starts dilating, increasing the diameter, which increases the radius, and then decreases the peripheral resistance, which increases your blood pressure. Okay? And if you really want to be particular, technically increasing the total, whenever you change your total peripheral resistance, you're really changing your diastolic blood pressure. So really, if you really want to be particular, this decrease in blood pressure is really diastolic. Is really the one that's actually decreasing. All right, that's good enough. Now, what about this oh, wait, one more thing. What about this? Remember we had these fibers, these weird fibers that actually come completely out. They don't actually stop at the chain ganglia. They pass through the chain ganglia and they come to the adrenal medulla where the postganglionic fibers are. And these postganglionic fibers release certain chemicals. What were those chemicals here called? It was called epinephrine and norepinephrine. And if you remember, 80% of it was epinephrine, and then 20% of it was norepinephrine. In this situation, this process is not going to occur that much, right? So because you're inhibiting a lot of these sympathetic fibers. So if you inhibit the sympathetic fibers, you inhibit the actual adrenomedullary fibers. If this is inhibited, I release pretty much no epinephrine and no norepinephrine. If these are decreased, this can also, remember epinephrine also binds onto the alpha-1 adrenergic receptors. So if epinephrine is also inhibited in this area, because epinephrine, which was released by the adrenal medulla, also likes to act in this area. But in this case, there's a very, very low level of him, and that is because there's the inhibition of the cardiac excitatory center. Sweet deal. Now let's get into this green guy here. Okay, what is this guy here called? Very, very important one. This is the cardiac inhibitory center. And again, we said it's a part of the dorsal nucleus of vagus, the vagus nerve, cranial nerve 10. He has these fibers, these GVE fibers, okay, that are going to come out. And as they come out, they're going to give these connections here. Primarily, they're going to come through a specific type of plexus-like system here. And they're going to give way to the SA node. So they're going to give fibers to the SA node. And they're going to give fibers here to the AV node. So again, what fibers is it going? It's going to be going to the AV node. And it's going to be going here to the SA node. So it's also going to be giving fibers to the sinoatrial node, or the SA node, and the AV node, or the atrioventricular node. Now, when it goes to this area and it acts on the SA node and the AV node, what is it going to do? Also, let me actually even add on to this more. Let's say that I have the heart here. I'm going to draw just a quick diagram of the heart here, crude diagram. Let's say here's the SA node here, and here's the AV node right here. If we really want to be particular, the actual right vagus innervates the SA node, and the left vagus nerve is going to innervate the AV node. So again, what vagus would this be? Right vagus. You might see, well, that's not that important. It is significantly important, okay? This can determine a lot of different things if this is damaged, okay, if there's some type of severing of this nerve. Okay, so left vagus supplies the AV node, right vagus supplies the SA node, okay? Cool, now, question is, how does this parasympathetic or these vagal fibers influence the AV node and the SA node? You also might have noticed, I need to make this very, very, very clear. Watch this. See these? Let's say that this is also the vagus, and it's going to be going to the myocardium of the heart. These are pretty much null. There is almost no innervation to the myocardium. I need to make that very, very clear here. There is pretty much no innervation to myocardium, the actual contractile unit. There is innervation to the SA node and the AV node and AV bundle and the Purkinje system, but no innervation to the muscle of the heart, the myocardium, the contractile unit. Okay, what I want to do is I want to zoom in on this actual cell and see how the acetylcholine is actually acting on the SA node and the AV node and what it's doing. So let me real quickly come down here, and I'm going to draw here a cell. Let's just say I zoom in on this SA node or AV node cell. So what kind of cell is this? SA node, or it could be an AV nodal cell, or it could be any part of the actual conduction system. Again, bundle of His, right-left bundle branches, the Purkinje system, whatever. But these are the two main ones. If this vagus nerve comes over here, let's say here's the vagus nerve, and it releases out these fibers. It releases out a specific chemical. It releases what's called acetylcholine. Acetylcholine will bind onto special receptors present on the SA node or AV node membrane called muscarinic type 2 receptors. Okay? When it binds onto these muscarinic type 2 receptors, it activates what's called a G inhibitory protein. What happens is G inhibitory protein is going to bind onto adenylate cyclase. Let's say here is adenylate cyclase. But what it does is it inhibits adenylate cyclase. So now adenylate cyclase can't convert ATP into cyclic AMP. So cyclic AMP levels are going to decrease. If cyclic AMP levels decrease, the protein kinase A levels decrease. If this decreases, remember those special channels that I told you to remember that were very important, that were on the cell membrane, and they were for the calcium? These channels were very, very sensitive to phosphates, remember? Protein kinase A could phosphorylate these. Well, guess what? This is not longer going to happen, and the calcium entry is going to be decreased. Another thing that happens, you know this G inhibitory, there's actually three components of it. One is what's called the alpha inhibitory. That's the part that actually goes here and binds onto adenylate cyclase. The other part is a beta inhibitory and a gamma inhibitory unit. The beta and gamma inhibitory unit go over to a special channel in the cell membrane. And this channel is called a potassium channel. And what it does is it binds onto a little pocket here on this channel. So here it's going to come over here, this beta and inhibitory subunit, which we can say are combined here in this case. These two are going to come over here and they're going to bind onto this potassium channel. When they bind onto the potassium channel, it opens up the potassium channel and potassium starts leaking out. As potassium starts leaking out into the cell, what starts happening to the inside of the cell? It starts becoming very, very negative. As it starts becoming very negative, what happens to the internal environment of the cell? It starts hyperpolarizing. So what's the overall effect here? There will be hyperpolarization. If you hyperpolarize the cell, it's going to take a longer time for it to send action potentials. So if there's a longer time to send action potentials, what is this going to do to the heart rate? That means the heart rate will decrease. If the heart rate decreases, what does that do to the cardiac output? It decreases cardiac output. If you decrease cardiac output, you decrease blood pressure. Okay? And how do I know that heart rate will increase cardiac output? Decrease in heart rate will decrease cardiac output? Because there's another formula. This formula is that saying that cardiac output is equal to the heart rate multiplied by the stroke volume. So again, if you decrease heart rate, you'll decrease cardiac output and you'll decrease your blood pressure. And again, that's what we're trying to do here because the blood pressure is too high. Now you might be like, oh, well, it doesn't affect the contractility of the heart. No, no innervation to the myocardium, so it does no contractility effect. Let me get another term straight here. If this is acting on the heart rate, if you're trying to change the heart rate, we'll talk about this more in cardiac output. But whenever you're trying to affect heart rate and you're decreasing the heart rate, that is called negative chronotropic action, okay? So acetylcholine or parasympathetic nervous system has negative chronotropic action. In other words, they are trying to decrease the heart rate. Whereas the sympathetic nervous system has positive chronotropic action. It tries to increase the heart rate, and it acts on the myocardium. It tries to cause contractility. So the sympathetic nervous system also acts as a positive inotropic agent. Okay, but the parasympathetic has no effect or no innervation to the myocardium, so it can't control the contractility. Okay, so far, what have we been able to do? We've decreased the heart rate in this person, so they might have some bradycardia. We decreased the amount of epinephrine and norepinephrine released from the adrenal medulla, so that'll decrease the vasoconstriction response. We inhibited the vasomotor nerve fibers that are going to the vessels and decreased the amount of norepinephrine release so that we're decreasing the vasoconstriction. Instead, we're relaxing the blood vessels, dilating them, and decreasing the total peripheral resistance. That's the ways that we've dealt with it so far. We also inhibited the cardiac acceleratory center to inhibit the sympathetic drive to the heart. These are beautiful things, but we still have to see how the body deals with it again, even a little bit more. If you guys remember in low blood pressure, okay, just so we're very, very clear here, whenever there was low BP, because I want to make a correlation here, it was actually stimulating your JG cells, right? The JG cells in the kidney. And the JG cells in the kidney were actually producing a chemical called renin. Now, what happened with the renin? The renin came into the bloodstream, and if you remember, there was another protein that was actually secreted by your liver, and that protein was called angiotensinogen. And this chemical gets acted on by renin, if you guys remember. And what it does is, renin is going to cleave a specific part of angiotensinogen and convert him into what's called angiotensin 1. So it converts them into a special chemical called angiotensin 1. Then what do we say happens with the angiotensin 1? Angiotensin 1 goes to the lungs. Whenever it gets to the lungs, what happens? There's a chemical in the lungs, right? There's a special type of enzyme. That enzyme is called angiotensin converting enzyme. What happens is angiotensin converting enzyme acts on angiotensin 1 and does what? Converts angiotensin 1 into angiotensin 2. And if you remember, this is the culprit. He was causing so many different problems, right? By trying to increase our blood pressure. Well, guess what? We have a special system inside of our heart. You know, in our heart, we have special atrial cells that have like a little endocrine-like tissue. And what happens is, let's say that I take this atria here, And I'm going to kind of just zoom in on it for a second. Let's say that I'm just kind of zooming in on that atria right there, right? So again, here's your aorta like this. And then here's the aortic valve, right? If I come into the atria and I start stretching the atria, okay, and why would the atria stretch? Because of a high pressure, okay? Because of high blood pressure, particularly some type of high left atrial pressure, which is usually due to an increase in what's called pulmonary capillary wedge pressure. If this is increasing due to high blood pressure, so because of high blood pressure, you're increasing your pulmonary capillary wedge pressure, which is increasing the left atrial pressure. This is stretching the atria. As you start stretching that atria, the atria has specialized endocrine-like cells a part of it. It secretes a chemical, and this chemical, I'm not even going to attempt to spell it, it's called atrial natriuretic peptide. Atrial natriuretic peptide is really, really cool, and whenever, again, there's increased blood pressure, this increased stretch on the atrial walls, it activates these special receptors inside of the heart that release this chemical called atrial natriuretic peptide. Now, this is why I told you that remembering specifically what happened in low blood pressure, this is going to make a huge difference. Okay, here we go. So we have angiotensin II here. He's one of the culprits of causing high blood pressure. So usually he's one of the main causes of trying to increase our blood pressure. Why? What were some of the things that he was doing? If you guys remember, one of the things that he was doing was he was coming here to the actual adrenal cortex. Remember there were special cells here called the zona glomerulosa cells? And they were being stimulated and releasing a chemical called what? Aldosterone. What else was happening? It was also coming down here to the what? Where the hypothalamus is. And it was acting on special receptors that are present within the hypothalamic. What were this nucleus called? I'm going to denote it, we already talked about it, supraoptic nucleus. It comes over here and it tries to stimulate the supraoptic nucleus, and remember, what does it do to the supraoptic nucleus? It activates action potentials that will cause the production of a hormone called antidiuretic hormone, ADH. We also refer to it as vasopressin. So also what else is it doing? If you remember, it was also coming over here to these neurons that control thirst and stimulating thirst centers, right? It was stimulating certain chemicals to be released, and these chemicals brought about increased thirst. Okay, so far, what have we already noticed? And that's not even it, surprisingly. So far, we've noticed it's caused increased thirst, it's produced ADH, and it's produced aldosterone. What else does it do? Remember, it has receptors on the actual vascular smooth muscle within the Tunica Media. There's angiotensin II receptors right here. Okay, there's angiotensin II receptors, so angiotensin II can also come over here and do what? He can bind onto these receptors. He can stimulate these receptors and cause vasoconstriction, right? So he can cause vasoconstriction. What else was he doing? Remember, he was coming over in the kidney too? He was coming over here to the kidney and he was acting on the proximal convoluted tubular cells. So if you remember, angiotensin II was also acting on the proximal convoluted tubular cells and stimulating this pathway to bring about more sodium reabsorption, more chloride reabsorption, and more water reabsorption. If we have more sodium, and if we have more water, and if we have more chloride, what does this do? This increases our blood volume. What do we say that does to the EDV? It increased the EDV, it increased the actual, we're not going to write all these things, but you remember, it increased the EDV, it increased the stroke volume, it increased the actual cardiac output, which increased the BP. So if it's doing all of that, that's another thing that's actually increasing the blood pressure, right? Also, if you want to remember, it also constricts what's called the efferent arteriole too. So it plays a lot of different roles. It also contracts the mesangium, the glomerular mesangial cells too. Not relevant in this topic, but just mentioning that it does have other functions too. Okay, so I gave you a little tidbit on angiotensin II, but the problem that I'm trying to get to is how does this atrial natriuretic peptide fit into this? Everywhere where angiotensin II is acting, atrial natriuretic peptide blocks. So for example, atrial natriuretic peptide will come over here and it will block this. Okay, it'll come over here. Actually, shouldn't have a stimulate. I should actually have an inhibit, right? So it comes over here and it inhibits angiotensin II from binding onto this receptor. If angiotensin II doesn't bind onto this receptor, then what happens? The actual smooth muscle starts relaxing. If the smooth muscle starts relaxing, it actually undergoes vasodilation. If it vasodilates, the diameter of the vessel gets bigger. If the diameter gets bigger, that means that the radius gets bigger. If the radius gets bigger, the total peripheral resistance decreases. If that decreases, the blood pressure decreases. That's another way of fixing the blood pressure problem. What else? We also said that angiotensin 2 acted to stimulate aldosterone production. Well, let's just follow this guy over here. He also is going to inhibit the production of aldosterone. So now aldosterone is not going to get released. We'll see what he does in just a second. Well, oh, angiotensin 2 also does this, Zach. You said he also causes the release of ADH. Well, guess what? Not anymore. He inhibits the release of ADH. He also comes over here to the thirst centers and inhibits thirst. If you inhibit thirst, are you going to bring in a lot more water? No. So if you're not thirsty then, so if you're not going to be thirsty, you're not going to bring in a lot of water. You're not going to absorb a lot of water across the GIT. If you don't absorb a lot of water across the GIT then, it's because your thirst is going to decrease. If you decrease your thirst, you're going to decrease your blood volume. If you decrease the blood volume, you're going to decrease the EDV. If you decrease the EDV, you decrease your stroke volume, which decreases cardiac output, and that then eventually decreases the blood pressure. That's one way that we can fix it, okay? What other way can we fix it? Okay, well, I told you it inhibits the release of aldosterone and inhibits the release of ADH. Okay, we should actually bring this down here to make it a little bit more conclusive here. It inhibits the release of ADH there. Okay. Now, if we inhibit aldosterone and we inhibit ADH release, how does that affect us? We'll come over here for a second. Where did aldosterone act? Let's do him in this red color here. So let's say here's aldosterone. If you guys remember, what did he do? Remember, he was a steroid hormone, meaning that he can pass through the actual phospholipid bilayer. He comes over here, he binds onto this intracellular receptor. This receptor steroid complex stimulates specific genes to produce 3 different types of proteins. If you remember, one of the proteins was for sodium channels, one of the proteins was for potassium channels, and then there was also going to be proteins over here in the basolateral membrane for sodium-potassium pumps. So what was it trying to do? It was trying to bring sodium in and trying to get potassium out. And then also these pumps over here were trying to bring a lot of sodium out into that area and a lot of potassium in, particularly 2 potassium in, 3 sodium out, right? That's what we're trying to do. And what else would we be trying to follow with the sodium? Water. Remember, water wanted to also follow the sodium? Well, if atrial natriuretic peptide comes over here and inhibits this action here, it inhibits the action of aldosterone. These channels are not going to be plugged into the membrane. That means that you're not going to reabsorb sodium. That means that a lot of the sodium and a lot of the water are going to go where? They're going to get lost in the urine. And you're going to urinate out a whole bunch of salty and watery urine. If I go ahead and pee out a lot of salt and a lot of water, what am I losing? I'm losing fluid volume. That means I'm having polyuria. I'm urinating a lot. So I have an increase, this means increased urine output. Okay, how does this affect it? That means I'm trying to decrease my blood volume. If I decrease the blood volume, I decrease the EDV. If I decrease the EDV, I decrease the stroke volume. If I decrease the stroke volume, I decrease the cardiac output, which decreases the blood pressure. Holy crap, right? So that's one way. Okay, what about ADH? Let's do ADH in this brown color here. ADH was coming over here at the collecting duct, if you guys remember. It was acting on V2 receptors. And then when it was acting on the V2 receptors, it was stimulating basically the plugging in of these channels. Remember these channels here? They were the aquaporin 2 channels, AQ2 proteins. So it was plugging these guys into the membrane by working through the protein kinase A pathway. And they were trying to bring what type of water molecule? They were trying to bring water in. If atrial natriuretic peptide is present, he is going to inhibit the ADH from being able to act on this receptor. So then what happens? All the water that you were trying to be able to reabsorb gets lost in the urine. And again, this also contributes to the polyuria, which is also referred to as increased urine output. You lose more fluid volume, which decreases your blood volume, decreases your EDV, decreases your stroke volume, decreases your cardiac output, and decreases your blood pressure. Holy sweet goodness. Okay? So that's the ways that it's dealing with it. Now, because of this, because the actual, our body trying to be able to bring our blood pressure back down, what did we see in relationship to these formulas? we saw the change in the heart rate. So how did our body try to deal with this high blood pressure? Well, one way is we tried to decrease the heart rate, right? Through the vagal motor system by acting on SA node and AV node, which decreased the cardiac output. Again, if you decrease the cardiac output, you decrease the BP. Another way is we tried to release atrionatriuretic peptide. If you release atrionatriuretic peptide, what is it going to do? It's going to inhibit the release of ADH, it's going to inhibit the release of aldosterone, it's going to inhibit the thirst centers, which is going to cause for you to lose a lot of fluid volume. If there's a lot of fluid that's being lost in the urine or not bringing in water through thirst mechanisms, then what's going to happen? The blood volume decreases and that decreases the stroke volume. If you decrease the stroke volume, you decrease the cardiac output. And again, if you decrease the cardiac output, you decrease the blood pressure. The other mechanisms was that we were inhibiting the vasomotor nerve center, so it wasn't releasing norepinephrine. We were inhibiting the cardiac acceleratory center, and that was also inhibiting the release of epinephrine, so there's decreased epinephrine release. And atrionatriuretic peptide was inhibiting angiotensin II. If you inhibit angiotensin II, you actually are going to do what to the radius? You increase the radius of the blood vessels because you dilate them. That decreases the resistance. If you decrease the resistance, you decrease the blood pressure. And this is the way that our body tries to compensate for high blood pressure. All right, Ninja Nerds, I hope all of this made sense. I really, really do. I hope you guys did enjoy it. If you guys did, please hit the like button, comment down in the comment section, and please subscribe. All right, Ninja Nerds, as always, until next time.